Thank you so much for being here with me today, Dr. Carla Stecco. We're so excited to have you at the Fascia Research Congress. And we're very honored to have you come and talk with us one-on-one today on the Mind-Body Connection podcast. Thank you.
Thank you. Thank you to you for the kind invitation. It's a pleasure to be here.
Yes, and we're in New Orleans and we're having a great time at this conference. There's so many really sharp minds here around fascia and the research. And I'd like you to tell us a little bit about where you're at right now with your anatomical studies and, what's the most juicy, really interesting part of your research going on right now?
I'm moving in the understanding how fascia could be altered during the different pathologies, because until a few years ago, I was focused more in the basic anatomy to understand what is really fascia and what are the differences between the different fascia, but just in healthy people. Now that we know at least enough about that, I'm moving to understand if the different style of life, the aging, the sex, or the different pathologies can affect the fascia and how the fascia are affected.
Yeah, so how fascia might change in a person's life due to all those factors.
Exactly. We know that the fascia has the receptor for the sex hormones. So the hormonal input can really change the amount of collagen fiber and elastic fiber inside our fascia. And probably the different female could feel in a different way the hormonal input, and could be more or less sensitive according to genetical pattern or other element, and that maybe can explain why myofascial pain is more frequent in female respect to male.
Wow, yes, I have not brushed up on that research, so that's very cool about the differences between sexes, because we definitely see a higher incidence of myofascial pain in females.
Exactly, but we know that we have the receptor for the estrogen, for the relaxin, but also for the androgen. And we have just published a paper about the androgen, and we showed that the female are much more sensitive to small variation of androgen respect to the male. And some years ago we published about the estrogen receptor, and we showed that the different level of estrogen changed totally our fascia.
In what ways?
The estrogen are able to decrease the production of collagen type 1 and increase the production of collagen type 3. So it means that our fascia became looser. Mm-hmm. And that is correct, because during pregnancy, for example, we need to have more space, more elasticity, but at the same time it means that we lost the stability related with the fascia.
Yes.
And maybe we can have more back pain, pelvic pain, because our thoracolumbar fascia maybe is less stable respect to the normal life. But we found similar alteration also in the periovulatory period. So also during the different day of the month, the mm-hmm. female, the fascial female is always undergo to changing.
Yeah, so dynamic. Every month dynamically changing, and then through the lifespan, exactly. Dynamically changing into different fascia.
Exactly. Yeah. And if we have an unhealthy fascia, we can tolerate this variation. But if we have already a fascia that is rigid or that is a limit of the compensation, mm-hmm. such variation can trigger the pain.
Yes, and so that brings us to discussing something very complicated like an EDS diagnosis, which can you inform us for our listeners what type of collagen is affected particularly with EDS in a connective tissue? disorder?
I have not done a specific study in the fascia about them. We have just done ultrasonographic study. And we expected, when we started to do that study, to see more gliding, more elasticity inside the fascia. And we were surprised that it is not true. It's totally the opposite. Our fascia, the fascia of the ADS became thicker and above all with much less gliding, because it's like a wrong compensation of a joint and muscle disorder.
Yes.
And consequently, from a clinical point of view, we started to treat the fascia of this patient that in the past was considered like a contraindication, because we understand now that we need to have a good gliding and a good elasticity in the fascia to allow that patient to have a good muscular recruitment and to be more efficient in the joint stability. But what is the problem? That they have a genetical problem, and consequently they come back. So we are not able to stabilize the result, but we need to treat the patient constantly. But working in the fascia, they feel much, much better.
And working in the fascia to be able to restore the glide.
Yeah.
Yes,
Yeah.
absolutely. I love pointing this out because as we spread more awareness and more teaching to clinicians too about how EDS would present in the connective tissue, it is true what you said, that it's counterintuitive. We wouldn't be able to pick up on a hypermobility spectrum disorder actually presenting with less fascial mobility.
Exactly, but in the past I was convinced exactly of the contrary, because they move more, so I expected to have much more gliding.
Yes.
So for many years, everywhere in the world, we say, no, we have not to treat such type of patient with fascial treatment, because they need the restriction of the fascia to increase the stability.
Right.
Now we know that is not true. We need to have an efficient fascia to allow to use at the maximum their possibility.
Yes, and so muscles can really thrive in that environment where the fascia can glide better. And tell me about fascial manipulation. This is something that your father started with originally, and you learned from him?
Exactly. Fascial manipulation is an hand-on technique, and was created by my father 40 years ago. It was one of the first physio to speak about fascia and how we need to address in the treatment not the muscle but the fascia.
Yes.
And he created a method that move far away from the joint and from the site of pain, to look at the globality of the body and to look where there are some fascial restriction that can affect also the body far away. So he teach me that we have not to be focused only where there is the pain, but we need to assess the patient in much more global way. So when I was at the beginning, I was not awake how much important is that direction. But after 11 years of medical degree, where I was focused only in the site of pain, and if a patient has a knee pain, you need to look only the knee, I understood how much revolutionary is the fascial vision. And I feel really a big conflict, because I remember that in the clinical practice at the hospital, I had to prescribe MRI, anti-inflammatory drug, corticosteroid. And they say, come on, with the hand my father can improve much faster and much better the symptoms. How I can just write that and suggest that to the patient if I know that there is something much better.
Yes.
And I decided to understand really why fascia is so powerful. But at that time, there was no research at all about fascia. So my first publication was about fascial innervation because we were not awake if a fascia is innerved or not.
Yeah.
So I started from that point, and I demonstrate that fascia is innerved and that can play a role in proprioception, in the pain perception, and from that, many other authors confirmed that fascia is innerved, and we start.
That is incredible. I love that your father was a foundational stepping stone that you took the next step from, and then you started to try to connect the dots and piece together. Why would our shoulder be restricted if the pain is in the hip or the knee and the shoulder relative, where the patient might not complain of their shoulder at all?
Exactly. But again, at the beginning, the big problem was to understand really how work this fascial continuity, because there was no photo about the fascia. There was just a few draw that was not really from dissection, but more the intuition of people.
Right.
I remember that there was just a big cross in the front to connect the hip with the shoulder.
Right.
Exactly. So the first time that I tried to do a dissection in the cadaver, I was not able to visualize this big cross. And I said, come on, where is this big fascia?
Right.
And I understood that we need to understand better fascial anatomy. So I did hundreds of dissection, and I published the first photographic atlas about the fascia that was important to show the people what is really fascia.
Yes.
And also the resistance of the fascia. I remember my professor in Paris that say, okay, maybe fascia could be interesting, but it's so weak that I don't think that can play any role.
It's just a covering.
Yeah, but also the idea is that it's something that you can destroy just touching.
Yes.
And every time I do this section for the student, I show that the fascia is very resistant. I can lift all the inferior limb through the fascia.
Yes.
So it's surely able to transmit the force, but also to create a restriction.
Oh, I love that. And visualizing those things in anatomy learning is so important, I feel like. It helps our brains retain that information.
Absolutely. I every time I do dissection, fascial focused dissection, also for postgraduate people, for people that have 50, 60 years old, so they have a huge experience.
Yes.
They say, now I am able to understand, because otherwise it's not easy to visualize and to understand exactly what is a fascia until you don't come back to the cadaver.
Yes, I love that. It's like we need to change our approach in every anatomical cadaver lab.
Probably, yes.
That exists. Really. Because of the 3D structural integrative properties of this tissue.
Exactly, but also I just did a speech at the Anatomical Congress, and they say, we know that in mean, the 30% of the muscular force is transmitted through the fascia and not through the tendon. So if you don't teach the student this, all the biomechanics, all the kinesiology is not correct.
Yes.
Because we are forgetting 30% of the muscular force.
Yes.
And how we can train well an athlete if we focus only in the muscular component, in the tendon component, and we forgot to train the fascia that work for 30%. I think that 30% can do a huge difference in the performing.
Absolutely. We can't overlook it. It has to be included. And I want to revisit the innervation of the fascia because I'm fascinated by this too. And I love that statistic that, did it originally come from your research about the 250 million nerve endings in the fascia?
I did many publications about innervation, also to distinguish the innervation of the deep fascia, of the superficial fascia, the visceral fascia. And what we know now that surely the fascia has a huge innervation, but not only sensitive innervation, there is also a huge amount of autonomic innervation. And now I'm very intriguing about the autonomic innervation into the fascia, because this autonomic innervation go around the vessel, and the fascia are very well vascularized. So it means that under sympathetic activation we can have ischemia of the fascia, and the ischemia of the fascia can create the fibrosis into the fascia that can remain also when the sympathetic activation is stopped. But we have also sympathetic fiber that go in the myofibroblast, in the fibroblast, in the connective tissue, and that can probably activate or change the function of the cell.
Yes. So this brings me to dysautonomia and our understanding of how to work with patients with dysautonomia.
I think that in this type of patient, at least in my clinical practice, I work more with the superficial fascia and the light touch respect to the deep fascia. Only in a second time I add also the deep fascia and deeper treatment. In fascia manipulation, we have the fourth level that considered all the interaction between the superficial fascia, the autonomic nervous system, the visceral component, but also the brain, the psychological component, because the superficial fascia is strongly connected with the skin, and help us to perceive the environment and to better adapt to the environment. If that is not working, it's a disaster for our body.
And that superficial fascia, so let's talk about it if we were speaking under the sympathetic reactivity, or can we just simplify it to the fight or flight? If we're in sympathetic activation, then what would superficial fascia behave like in response to that?
Every time we are under sympathetic activation, our fascia becomes stiffer. We need to remember that the superficial fascia is what remains of the panniculus carnosus in the animal.
Yes.
So the panniculus carnosus is what creates the rigidity in the back of the cat when it's nervous, or change the characteristics in the other animal. So it's really something that shows the reaction to some fighting.
Yes.
But if we have just a few minutes of this activation, it's not a big problem.
Right.
We can create the tension and then we come back.
Balance back.
Exactly. But if we are always under that sympathetic activation, our fascia remain under that tension and create fibrosis. And typically are the patients that say, I'm always tension in the shoulder, in the neck, because it's a very stressful period. That I will start immediately with the superficial fascia, not with the musculoskeletal fascia.
Yeah, so I love that you're understanding and teaching those distinctions of, we might call it like coat hanger pain. It's in that shape.
Yeah, exactly.
And how that is, presenting like a nervous system that has been ready to fight.
Exactly.
Or flight.
Exactly. And I think that really the sympathetic component can have huge role in our fascial system. We know that also the thoracolumbar fascia could be affected by the sympathetic activation. So if I have to beat, I think that the superficial fascia is more prone to sympathetic activation because up to now, we know that she has almost the double of the sympathetic fiber of the deep fascia.
Okay.
So we have much more sympathetic fiber, autonomic fiber in the superficial fascia because the superficial fascia is the fascia that control the thermoregulation, that control the pressure, all the feeling that come from the outside component. So the sympathetic and the autonomic part is much more evident in the superficial fascia.
Very cool. I love seeing that as almost like our protective layer.
Exactly.
Yeah.
In a sensitive way, in a conscious way, but also in an unconscious way. Mm-hmm. And always I try to awake my student that also when we are seated like now, we have all the perception of the different pressure in our buttock, but we are not awake about that because we are just speaking. But our body feel all the time, and we have a different reaction in our subcutaneous tissue to compensate that pressure.
Yes.
And but if we have a wrong fascia or that is too rigid, we have a bad feedback that is not only conscious as a pain, but maybe is simply unconscious. It's something that creates a discomfort, something that we are not able to. But at the end of the day, that can create a lot of problem.
Yes.
So the release of the superficial fascia is really help the people to feel better.
Yeah, absolutely. And receive better proprioceptive input too, which continues to engage with their motor cortex better.
Of course.
Mm-hmm. Giving them better coordination and all the things that they need to progress in movement.
Exactly.
I love this conversation. I focus a lot with body awareness in my EDS population, but now you're making me think about it in a different way, in a more microscopic way of what kinds of approaches or methods do you feel like work best in helping influence that superficial fascia to make it healthier?
I think that first of all we need really to learn how to discriminate if it's a problem of the deep fascia or of the superficial fascia, and consequently to have a three-dimensional visualization of the fascia and how deep we are palpating and touching is important.
Yes.
Because the superficial fascia, if I do just like that, I have pins like that, I have between my two fingers the fat and the superficial fascia, but the muscle and the deep fascia remain under.
Yes.
I'm not affecting in that
not
way.
Not moving it.
The deep fascia. If I do like that, I pull like that, I'm affecting more the deep fascia. So the different technique that we know in rehabilitation work in a different way in the superficial fascia and in the deep fascia. And consequently, we can use them to do the diagnosis, but also the treatment.
Depending on the difference in pressure you might use, or even
the different pressure, the different modality, if it's a pinching or if it's a pressure. Also, if I try to do like that, the gliding, I'm trying to understand the relationship between the superficial fascia and the deep fascia. So we have many different ways, and coming back to the anatomy, we can put like an order in all the different manual technique, but also physical technique that we have to understand how deep we are palpating, what the input we are giving to our fascial system.
Yes.
And why now I'm so interested to understand better the fascial alteration? Because if I understand that in lipedema, for example, we have a lot of inflammation, I don't need to create other inflammation.
Yes.
I need to work to decrease the inflammation.
Right.
But if I have other patient, for example, a chronic back pain where there is not too much inflammation, but there is more a disarrangement of the collagen fiber,
Yes.
I need to work more in the restoring the correct line of force.
Yes.
And maybe I can work more with the exercise, with the tension.
Decreasing stiffness in that
Exactly.
case. I love all of this. It's wonderful because it's leading me to feel very hopeful that there's more specific lines of treatment according to the pathology.
Exactly, is my dream because I really don't like the discussion. This treatment is better of that.
Yeah.
It's not a sense.
We could all sit in a big round table and discuss our passion of how this is better. Yeah.
But what we need to understand is what is the alteration, and among all that treatment, what is the best treatment to improve as fast as possible that alteration?
Yes, absolutely. And we know every patient is so individual.
Exactly. So, and what I like of the vision of my father is that really is a personalized medicine. He always told me that all the patients are different. You can't never treat in the same way. To different patients.
Yes.
Because the back pain in one patient can come more from the inferior limb, in another more from the shoulder, from the front. So you need to understand why the thoracolumbar fascia, for example, is under tension and is triggering pain. But she's so connected with all the body that that tension can have origin in many different parts.
Yes, absolutely. And so in regards to the innervation of the fascia and the different layers, then one of my loves in my own practice is diaphragm work and breath work. And seeing the shift in a patient from a sympathetic driven nervous system or anxiety or fear into relaxation and calm and safety. So can we speak about the innervation and the fascia of the diaphragm?
It's a nice topic. The diaphragm, I think that is not just a muscle, because really is above all connective tissue. When we look at the diaphragm, the muscular component is the minimal part, but we have a huge component that is the connective tissue.
Yes.
And we need to remember that the diaphragm is strongly connected with the liver and with the coronaric ligament, the falciform ligament, but on the top is connected with the pericardium.
Yes.
And through the pericardium, we arrive, the pericardium is connected with the fascia of the thymus, and the fascia of the thymus is connected with the fascia of the thyroid. Yes. So we have a huge connection that is not only transversal, but is also longitudinal.
Yes.
And that in the clinical practice is very important. But coming back to the innervation, we know that the diaphragm is innerved by the phrenic nerve. But the phrenic nerve, again, is not only a motor nerve. Half of the fiber of the phrenic nerve are autonomic nerve fibers. And I think, and they don't go only to the diaphragm, but they go also to the capsule of the liver, to the pericardium, to the capsule of the thyroid. So we can understand how all the fascia related with the diaphragm have the innervation from the phrenic nerve, from the autonomic component of the phrenic nerve.
And, you know, vagus nerve has gotten a lot of spotlight. Thankfully, people are beginning to speak of vagus nerve more commonly. And I sometimes have patients come into the clinic and they'll ask for vagus nerve techniques. Can we hit on that in combination with this complexity you just spoke about?
Yes, surely the vagus nerve is very important and is related above all to the parasympathetic component. I see the vagus nerve strongly related with all the visceral component that we have in our body.
Yes.
But what I want really to awake that the dimension of the phrenic nerve and of the vagus nerve are not so different.
Yes.
So we give a lot of importance of the vagus nerve, but really probably we need to strengthen the importance also of the phrenic nerve that is more related with the diaphragm.
Direct innervation.
Yeah.
And in the fascial innervation, how do we, so that's where your frontiers of research are going, right? To distinguish like where this nerve is distributed in the fascia?
Is surely an important topic where the research is really, really at the beginning.
Yeah.
But what is important to understand that our visceral fascia are very different because we have, for example, in the peritoneum, the visceral peritoneum is innerved by the vagus nerve and all the autonomic system. The parietal peritoneum is innerved by the somatic nerve that share with the musculoskeletal system the same nerve root. So the visceral fascia some have autonomic innervation, others have somatic innervation.
Uh-huh.
And when we have, for example, a cancer in the stomach, we have no pain at the beginning because the visceral component and the visceral fascia have no somatic fiber.
Yes.
But when the cancer affects the parietal fascia, the parietal peritoneum, and so on, it's become very painful.
Yes. The sensory feedback is part of that system. Mm-hmm.
So we have two different perceptions of our viscera that work in different way, and it's incredible the integration that we can have at that level.
Yes, and so that brings us full circle really to interdisciplinary collaborative discussions like that are happening here at Fascia Research Congress.
Exactly, and it is really my dream because often the surgeon, for example, don't take care of radiating pain because are not in the site of the surgery.
Yes.
But if we understand the fascial continuity, we can understand that the surgery could be the cause or the concause of another problem.
Yes.
And my dream in the future is that we can take a better care of the fascia during surgery to avoid that type of consequence.
I love that. Thinking about that playing out in the world of medicine and surgery where patients could heal faster and have surgery that really does fix the problem better.
Exactly, because I think that thanks to the fascia, we can have a better understanding of the patient. So probably we can avoid many unuseful surgery because we can really discriminate if the problem comes, for example, from the knee. So we need really the knee surgery.
Yes.
Or if the knee is just a referred pain of something that comes from another side.
Yes.
And consequently, we can avoid that type of surgery. And also for the recovery, if we respect the gliding between the fascia, if we suture in the proper way the fascia, I'm sure that the recovery is much faster.
Yes, that is wonderful. And I hope that your visionary teaching and your knowledge base reaches everyone who's going to touch a patient.
That is for that reason that we need such type of information.
Absolutely. Thank you for sharing with us. Thank you so much for doing the work that you're doing in the world of medicine and teaching. And thank you for being here at the Congress.
Thank you to you to help me to share the information.